patients who are dropping in or coming to the dental OPD. So we had all the approvals, ethical approvals, and finally we isolated the sample from the mouth of the probable patients in the OPD of the hospital, which is on campus. We went in for plating them by using the various common techniques like blood agar plate technique. And finally, we undertook the bile esculent test, and that blackening, you can just appreciate the blackening of the tubes here, which tells us that the sample which we have cultured and have isolated is primarily having the Enterococci species. We further submitted it for other tests like biofilm assay, and we were in a position to confirm that yet the population which we had targeted is having or housing the bacteria of the Enterococci species. You can just see a sort of a statistic supporting this. We were able to have clinical isolates from a good number of patients, and we could see that the patients who were in the range of 40 to 60 degrees, I'm so sorry, 40 to 60 years, were the ones who were having the Enterococci positive frequency. And this is in alignment with most of the research and the survey studies done, that the patients who are in this category because of the age and because of the hormonal changes, because of the smoking or other habits, are more susceptible to oral afflictions than any other category of patients. And as I had said in the beginning, that the number of males were the ones which were more sufferers, and as compared to the women who were suffering 40% at the 40% level. We were able to then isolate the E. faecalis by the virtue of biofilm assay. There are certain categories and means and standards by which we do. We took the oral swab and periodontal swab, as I just told you, and we could find out that as per the standards, the standard protocol, our samples were having the sample of E. faecalis. So the E. faecalis was then confirmed by another test, which is called as the gelatinase production test. It is understandable. I think some of us might be teaching pharmaceutical microbiology, so we understand it very well, that for the identification of a bacteria, the metabolism which happens through it, the substrate which is used, can be an indicator that what type of bacteria it is. So if a bacteria is able to produce gelatinase, it is one of the attributes of the Enterococci faecalis. So we could get that value very well, and we could actually ascertain that with certitude that yes, this samples which we have taken from the patients, around 76.92% were of the Enterococcus faecalis, which was our target microorganisms. We subjected to the next important step. If you remember, I was just mentioning a bit back that it is high time that we do not let our antibiotics go dud and let them not come under the banner of resistance, and try to salvage them as much as possible. So we did a small study where we found out that what is the susceptibility of this isolated E. faecalis towards the normally given antibiotic. So that study revealed that ciprofloxacin primarily is the one. Listen, the statement is important, that out of all the antibiotics, ciprofloxacin was the one which was presumably going to be resistant for against this E. faecalis. So what we did was that we wanted to salvage ciprofloxacin, which is an age-old drug, which has got a beautiful antibiotic spectrum, and we did not want to go it down the drain. So we took ciprofloxacin deliberately as a drug, which we would manipulate and fortify and maybe make strong by using the nanotechnology trends, and then try to see that its conversion into a new drug delivery system like a nano-emulsion or a nanofiber is able to salvage this drug and help it to become susceptible rather than resistant to that particular microorganism. Let us see the journey from here. We took the drug. I would skip this slide. They're typical of pre-formulation slides, which we did for all the work, supporting the authenticity of the drug sample, finding it out the way, having calibration curves, and so on and so forth. The formulation development was very, we had two things in mind, that we'll try to develop two types of formulations. One which we chose for very obvious reasons was the nano-emulsion, and the second one which we was wanting to, and we had a collaboration with the Center of Nanoscience in JNU, and which we wanted to convert the ciprofloxacin and load them into nanofibers. So these are the two formulations. If the time permits, I'll take them in detail. Otherwise, I'll rush you through so that you get a feel of what we had been doing. So when we talked of the nano-emulsion, which was loaded by the ciprofloxacin, there's a lot number of papers who support their presence, the way way they can be encapsulated, and so forth. So we understand that nanotherapeutic intervention would help us to have an enhanced efficacy. It might diminish the resistance. So with that hypothesis in mind, we primarily looked into a nanotherapeutic pharmaceutical approach for the destruction of the biofilm by virtue of the sort of small size and many other attributes of a nano appended system. We are aware that there is a huge number of nano formulations which are available. Each one of them have got their own positives, own negatives, and we had to be very sort of selective, and we have to have a microscopic eye when we have to get the attributes of a system. And so also the chosen antibiotic, we have to take care of the pharmacotechnical attributes, not to mention that we had that thing in mind that it is on the verge of resistance, so let us try to salvage this. So these were some of the reasons why which we selected the nano formulations, which I just mentioned, namely the nano emulsion and the nanofibers. We had this category fluoroquinolone, and that is the category to which ciprofloxacin belongs. We have questions which will be answered shortly, that why we, and we typically went in for a water in oil nano emulsion rather than a typical common oil in water nano emulsion. The nano formulation was primarily planned in a manner, or it was sort of visualized that it would have anti-biofilm activity. So you can see this orangish color dots are sort of your nano emulsion thing, which is having the bioactive or the active ciprofloxacin. And this ciprofloxacin, primarily while it is in the nano emulsion form, will deposit on in and around the mantle of the biofilm. And by virtue of certain ingredients, and I would now mention it, that it was oleic acid, which we took as a functional excipient, which was in a position to do the disruption of the microcolonies. And finally, the ciprofloxacin, which was not able to enter into the sort of biofilm protected bacteria, was in the same concentration able to kill the microorganisms. So in a nutshell, what we are trying to impress upon is that the nanoemulsion, by virtue of its small size and many other sort of attributes of a nanosystem, was in a position to disrupt the biofilm. And after the disruption, the antibiotic, which was helpless before, became absolutely sort of like a soldier with an armor, and was able to kill the microorganisms with full intensity and at the same potency at which it appeared to be resistant. So that was the basically take home message. And the supporting paper of rabinatol, it was like a huge sort of rescuing paper for us, because we were not in a position to get many references where this excipient of oleic acid was actually touted as. We had fleeting references hither and thither that oleic acid can be one of the functional biofilm or potential biofilm disruptor. But this paper came handy, and we were like more confident, and luckily our research outcomes were very much aligned to the proposed research outcomes of this paper. So I deeply acknowledge the author here. So we know what oleic acid is. It is basically an unsaturated fatty acid. So as we started with the nano emulsion formulation journey, the first step is primarily the selection of oil. So we chose I may just very quickly mention here that some of you must be aware of the concept of oil pulling in the mouth. And you must also be aware, I'm sure you must have heard or maybe used it yourself, that coconut oil and olive oil are very commonly used oils for oil pulling and cleansing of the mouth. So that was one reason that we chose these two oils and oleic acid for the purpose which we have just explained. So we found out that amongst the three oils which we had pre-selected, the one which was giving us the maximum solubility of the drug was the oleic acid, which primarily was also very helpful in order to load more drug. Then similarly, we went in for the selection of the surfactants, the co-surfactant. I need not get into the details. I trust most of us are aware that how we progress to make a nano emulsion, and selection of a surfactant and a co-surfactant, then followed by an S mix, and then titration method with the water is a very common thing. The only thing which primarily is to be remembered here, you can very well see the ternary phase diagrams, which are now the software based construction is happening nowadays, and we could find out that which of the areas is giving us more, which of the ratios of the oil and the S mix is giving us more amount of area for the nano emulsion construction. We had two methods which we devised. One was the low shear method, the other was the high shear method. The low shear method, as I was just telling you, is the aqueous phase titration method. the simple method, but the outcome was not very favorable to us. Although it was not that I would say disagreeable, but we wanted a system which was having a little lesser size so that we can have more surface area and better deposition in and around the plaque or the biofilm. So we went in for the you can see that the size here is 240 nanometers. But as we went in for the high shear method where we use the ultrasonicator, we were in a position to get a size which was much lesser than that. So it was around, I would say, this was around 72 nanometers, the average size. So we had the various other, I would say, characterization parameters where we subjected the formulations to centrifugation, then heating, cooling, thaw cycle, and found out that which formulation was the one which was having the appropriate viscosity, pH, refractive index. So in a nutshell, I just want to very quickly and fleetingly let you know that, of course, any formulation would be having a lot of what we call as characterization parameters. So needless to say that all of these characterization parameters were taken care of. And then we also went in for fluorescence microscopy. I would mention here that most of us get a lot of sort of issues when we talk about the water in oil nanoemulsion. It cannot be subjected to transmission electron microscope, which usually is a very dependable tool. And because of the presence of the oil, the electronic beam would not pass. It would be some repulsion and some issues will be there. So we only heavily depended on the fluorescence microscopy method where we were in a position to see the circular shape of the nanoemulsion, and we did not have any doubt that the nanoemulsion was very well constructed. The size analysis supported our result. The zeta potential of -28 was a huge respite, and that told us beyond doubt that the formulation which we are sort of working at is been optimized. As we move further, we have to go in for the in vitro studies. We were in a position to have a burst release of around, let us say, 15 to 18%, and then we could see the difference between a pure solution of ciprofloxacin and a nanoemulsion. And of course, you can appreciate the sustained release of the formulation. We subjected routinely to the pharmacokinetic, this release kinetics parameters, and it was revealed that it was following the first order followed by the Gauss-Mepper pass. And it also followed the Fick's law diffusion, which said that, okay, the diffusion is the mechanism for the drug release. The next section was dealing with the biofilm assay. And this biofilm assay was primarily one of a very interesting study where we could reveal that you can just see the lightening of the color of the crystal violet, and that was helping us that there's an inhibition of the biofilm. That was a big sort of help to us. And not only the nano emulsion which was carrying ciprofloxacin, also the one, this is the picture of a 96 well plate. So not only the nano emulsion which was holding or having ciprofloxacin encapsulated, rather the placebo nanoemulsion, which was having some amount of folic acid, also showed a little bit of biofilm disruption. So that was a reiteration of the fact that oleic acid and the quantity in which we had used was sufficient enough to disrupt the biofilm and result in its inhibition. So you can just see that when the ciprofloxacin, the minimum biofilm inhibition concentration was as less as 16 micrograms, and the minimal biofilm eradication concentration was 64 micrograms for our formulation, which is the ciprofloxacin nanoemulsion. On the other hand, the one which we had used, the ciprofloxacin plain solution, which was maybe akin to the standard way of reaching the drug to the film, you could just appreciate that there's a huge amount of increase in the micrograms per ml value for the inhibition as well as eradication. In comparison, so what do we conclude from this study is that the ciprofloxacin, when encapsulated into a nanoemulsion, was able to rescue us in a manner that it was still acting as an antibiotic, and it was, I would say, sort of salvaged. And maybe we can conclude that a ciprofloxacin encapsulated into a nanoemulsion would still remain active in killing the Enterococci fecalis, and it would not allow it to be resistant. However, if ciprofloxacin was given in the solution form, the contrary was the response. You can see the visualization of biofilm. You can see this is a biofilm. You can see the closeness of these cells, and everything is so intact. It is like your plaque which has been removed and then seen under the microscope, fluorescent microscopy. Here, after the destruction and the formulation treatment, you can see that the biofilm is completely broken up. So it is akin to the diagram which we showed, that once the biofilm is broken up, it will reveal, or it will expose the microorganisms which will be planktonic in nature and which will now become susceptible to the killing of by the killing of the antibiotic. The stability studies was done at different temperatures as per the protocol. Then this publication came handy after this whole work. So we were in a good position, and this publication came very easily to us. And it was on the exploration, all the things which I've just explained that was put up. You can just see the diagram, the graphical thing which we had just discussed was presented in this paper. Then we move to the next section, although I am short on time, so I will very quickly take you through the slides, maybe not getting into the details of it. The next formulation was the nanofibers. As understood, it would be a good nanotherapeutic intervention. It will have its own advantages like a good length ratio and a volume ratio, and the construction of or formation was done by an electrospinning machine. We are obliged to the co-investigator, Dr. Pratima Solanki, for helping us out with these apparatuses at her lab. And we were in a position to select different types of polymers. We tested various polymers, had different optimization parameters. You could see on your screens the nanofibers constructed from the polymethyl methacrylate, polyvinyl alcohol, and polyvinyl pyrrolidone. And it was deduced that the polyvinyl alcohol and PVP, being hydrophilic in nature, the sturdiness of, you can see they're a little more fragile as compared to the one with PMMA. So we were wanting something intermediate to get that sort of intricacies of PMMA as well as the PVP. We just had a combination of this, and finally we had a formulation which was made with a combination of PMMA and 10% of PVA. You can see this is an aluminium sheet which is having this whitish film, and these whitish particles, whitish thing which we are seeing, are very, very fine fibers which have been taken out from the, so this usually is referred to as a nanofiber sheet. Then you can see and appreciate that the ones which were in combination with the PMMA and PVA are a little more sturdier as compared to this is a little sticky, being a hydrophilic in nature, whereas this is a little more thicker. So maybe the release would be an issue with this, and it would be a little longish, but we want some amount of drug to be released earlier as well. So we went in for a combination of these two polymers, which was very successfully handled. And then as we moved further, we were in a position to get the SEM scans, and you can see the average diameter which has come out. This was the one which was a combination one, and we had a polymer average diameter of 243 nanometers. The various other parameters like X-ray diffraction, FTIR, differential scanning calorimetry, TGA was all conducted in order to support our optimization, which is a routine practice. And finally, we went in for the finding of the degree of swelling, because when the fiber will be inserted, there will be a lot of amount of gingival crevicular fluid. So that would be good quantity there. So that we insert a dry fiber, the cavity will hold the dry fiber, but a continuous secretion of the gingival crevicular fluid will be sort of deluging it, and if the polymer does not have the capacity to absorb the water, the release will not be there. So this degree of swelling is a good idea to find out that whether your fibers are amenable to flexibility and swelling and delivering the drug. We also went in for a simple tool of an atomic force microscopy to just to get a topology of the fibers. You can just appreciate the shape which is being revealed by the atomic force microscopy study. And different polymers appear differently. The one which we are taking as an optimized formulation was very smooth, and it was primarily absolutely the way we had seen it in the SEM as well. Both the things were corroborated. We went in for the in vitro drug release, and one of the things which actually was revealed was that the drug above the minimum inhibitory concentration was present there for not less than 22 days. So we had a burst effect of the drug in the first 5-10 hours, where we are having 40% of the drug released in the cavity. But as the point process, the fiber is there inside the cavity, it keeps on releasing the drug, and primarily it is there for a good 22 to 23 days. So this became, then we had the drug release kinetic study, and followed by the biofilm assay studies for the nanofibers. We did the antimicrobial bioassay and found out the zone of inhibition, which helped us understand that yes, it was effective to kill E. faecalis and also E. coli and Asorius, which can be found commonly. The antibiofilm activity also released out the results that yes, the combination which we have chosen along with the ciprofloxacin loading was good enough to give us an antibiofilm activity. The stability studies, as usual, were conducted. This paper was also published. The second part was also published in another journal, Applied Polymer. Then the longevity of the release and the stability of the formulation and all, it helped us to get a patent in a record less than 1 year. And we were granted this patent on the nanofibers of antibiotic for inhibiting formation of biofilm, and that came to us a little less than 365 days, which is in itself a big record for any university sort of group. So I dedicate this patent to the hard work of my PhD group, and particularly Miss Manvi, who was the one who had actually done most of the desk work. The summary is like we were in a position to create two sets of formulations. One was a nano emulsion, which could be very successfully used for the destruction of the biofilm. And on the other hand, we also had the nanofibers construction, which was also a good tool for us to actually treat the periodontal infections. So that is what all I had to share today. These are some of the references which we have very sort of using and heavily relying on. A big thank you from my side. I thank each one of you who patiently listened to my presentation. I'll be very happy if any questions which needs sort of deliberations and gratifications. I'll be very happy to gratify any of the queries raised by your good selves. Thank you so much for this opportunity. And of course, I am open to all the questions and all the support from my end. Thank you so much.
So I should like to thank Iqbal for such a it's really an honor to madam whenever is this whenever there is a short-term training program or any type of the webinars, it's all to increase the knowledge as much as you can. Now, as madam is having a very short of time, so I will request all the participants to have your queries.
Thanks, Ayan. Good morning to you as well. I'm good. How about you? Thanks for asking. If there are any queries, you may unmute yourself, or if there are certain things in the group, my question is, what are the potential advantages and challenges associated with these approaches? Well, that's a wonderful question. I'll give you a case. I will give you a case scenario. You are having a toothache, or you are having a pulpy tooth, or maybe some other infection. You are being given 250 uh, milligram of metronidazole thrice a day, maybe twice a day, and maybe for 4 days, 7 days, and 10 days. If you just do a rough calculation, you are loading your body with a huge amount of metronidazole or any other antibiotic for that matter. But the thing which is required to kill the microorganisms, you will take it orally, it will go the whole way, and finally, when it reaches to the tooth, it is much, much more diluted. What a good idea that if I'm just releasing my drug in the periodontal cavity and to the tune of just 1 milligram. So I'll put it this way: 1 milligram of ciprofloxacin in a nanofiber equivalent to 1000 micrograms, which will get inserted into the cavity and released over the next 22 days. And you are not needing to unnecessarily burden your body with a lot of oral antibiotic. So, what a good idea of just reducing that drug to 1 milligram in place of grams together. No problems of antimicrobial resistance, no issues of your upset GI tract, and you are delivering the drug right in the periodontal cavity in the form of a longish fiber or your nanoemulsion or your nanoparticle, which can be inserted directly into the cavity. I trust I am able to gratify your query.
Sam, please answer.
Thank you so much. Thank you so much, Sayan.
If anyone is having, please be fast.
Thanks, Sayan. You're welcome. You're welcome.
If
I
any of
think
the other faculty
there are
or
faculties across the state, or they're from other parts of the country as well, sir.
if any of the faculties are having any questions, please. I want to give you a soft warning that madam is having a short of time, so please be ready with your questions and just do it as fast as possible.
I'm writing my email ID. If at all there are any questions which you think should reach out to me, I'll be very happy to gratify them through a mail ID. And Roy sir knows very well that I am very keen to interact with the teachers and the students and contribute in whatever manner. Pragati has a question. What are the in vivo studies we can work on? Of course, we have got one of the most reliable model is a beagle dog model, but which is out of our reach. We have a model which can be sort of developed into a rabbit, and you can have a periodontal cavity by giving a high sugar diet. And we also have another method by which we can just tie up the suture along the canines of a rat, and finally give it a high sugar diet. And after some time there will be inflammation in the gingiva, then we can apply the formulation, then we test it. There is one paper by our group only. You can look into the various animal models which can be used for this study. Pragati, I trust I have been able to gratify your query as well. The paper is available freely. I think it was published way back in 2011 or 12. So if you just Google that out, you would be able to find that. Animal models for periodontitis.
So any more queries?
You're welcome, Pragati.
So any more queries, please? Please be fast.
You may unmute yourself if you wish to, and then ask directly, or you may type in the sort of message window.
We are waiting for your comment.
It's fine, sir. They might even mail to me, and you might share my number with them. They can WhatsApp to me as well if they wish to.
Okay.
My only request is that I would love to have a feedback and maybe improvise on the things which you would like to hear next time, or any other deliberation shortly, sir. So that
sure, ma'am. Sure.
That's it.
So it's an honor to hear from you, madam. It's an honor
Thank
to
you,
hear
sir.
from you. And I think everyone has increased their knowledge a lot, because madam is truly an ocean of knowledge. I'm not exaggerating the things, but madam is an ocean of knowledge. So I think that if you have got a few drops from the ocean, that will be enough for you to build up the career. And madam's email ID is there with you, so you can have any questions afterwards. After going through all the slides, which we shall be sharing with you, so within a few minutes. So I will be not taking more time of madam. So I think that madam will be engrossed in some other activities. So wish you a very thanks, ma'am, for being here.
Thank you so much, sir. It is I always say so, and I'll repeat it, that it is always a pleasure to be amidst the teachers and the students, and I am always very sort of enriched myself whenever I have a conversation with your good self. Thank you so much for this great opportunity, sir. You have always been so kind to me. Thanks a lot, sir. If you allow me, I'll leave the meeting, sir.
Yes, ma'am.
Shall I
Yes,
leave the
ma'am.
meeting, sir? Thank you so much.
Yes, ma'am.
Thanks each one of you. Thanks a lot. Hope to meet you
Thanks a lot,
sometime.
madam.
Hope
Thank
to
you,
meet you
ma'am.
sometime down. Thanks a lot. God bless you all. Take care.
Thank you all. You may all leave the meeting.